So let's take a look at the regulation of the system. Now, what you have to remember is that both systems are going to be regulated by estrogen in terms of its effectiveness off of the hypothalamic signals because of the development starting off on the neutral organization, which happens to be the female organization, in which we have distinct nuclei within the hypothalamus, including the preoptic, the anterior hypothalamic, the paraventricular, the ventromedial, and the mammillary bodies, which will all be involved within the regulation pathway. Now, if you remember, these are the same pathways that are involved with thermal regulation and is part of the reason why, as females age, as the estrogen sensitive cells within these areas start to get fluctuations with FSH and estrogen, become hypersensitive to changes in thermic activity. These areas are also going to be sensitive to levels of leptin, as well as involved with the psychological and somatic responses and modulation to things like oxytocin and prolactin, as relates to changes of those hormones in regards to either psychosexual arousal or nurturing of kin relationships. All of these centers are going to be regulated by a hypothalamic protein known as kisspeptin, as well as be regulating the anterior pituitary through gonadotropin releasing hormones. So for both of the systems, regardless of gender, we're going to be looking at hormones of gonadotropin releasing hormone, follicular stimulating hormone, luteinizing hormone, intragonadal signals of activin and inhibin, levels of inflammatory cytokines allowing for normal regulation, pubertal and secondary regulations, adipose cytokines, especially leptin signals, prolactin and oxytocin will all come into play as relates to regulation of the system and the tissues associated with reproduction. In terms of female specific, we have things like estradiol, which is the active form of estrogen, progesterone, for birthing purposes only, relaxin, as well as regulatory hormones, activin and inhibin. We will have secondary hormones coming into play, such as prolactin and oxytocin, where prolactin and oxytocin are going to have a role in the regulation of mammary gland functions as it relates to cycling and cycling reflexes, as well as oxytocin's regulation within the orgasm reflexes associated with psychosexual arousal, as well as bonding with kin and with the infant during suckling. This is a cyclic circadian regulation based off of pulsatile releases of FSH and LH, in which FSH is going to be regulated on a positive feedback loop early within the cyclic circadian pathway, where FSH is going to induce estrogen and estradiol will induce additional FSH, which will trigger the release of LH within the pathway. We're not going to go through the stages of the development as we've already done that, but what we have to remember is that as we go through the pathway, the ovule is going to be released following regulation of FSH and LH, where estrogen is being produced by the secretory cells within the ovary, and progesterone will be secreted by the follicle and the corpus luteum following ovulation and the luteal phase of the ovulation cycle. So let's go ahead and take a look at the cycle, and then we'll take a look at its cyclic regulation. So we start off with having normal levels of adipose, normal nutritional status, and environmental stimulus, allowing for kisspeptin to regulate GnRH release. GnRH is going to head to the anterior pituitary to induce FSH, to induce ovary and follicular development, which will induce estrogen release, which will stimulate GnRH release to trigger more FSH and now LH release. FSH and LH will induce ovulation, which will induce both estrogen and progesterone to head into circulation. Corpus luteum will continue to be active, producing progesterone and estrogen. It will also start to produce inhibin. Inhibin will start to inhibit the activity of FSH as well as the sensitivity of FSH to GnRH and to kisspeptin. Estrogen will head into circulation, at which point in time it will start to inhibit all those things that came before it. progesterone will head into circulation and it will start to inhibit the production of LH as well as everything that came before it. In circulation, it's going to allow for gestational female development. It will, upon puberty, allow for secondary sexual characteristic development. It will allow for the maintenance of the uterus during gestation. It will allow for engorgement of the mammary glands through hypertrophy and hyperplasia in association with prolactin, but it will not allow for lactation to take place as long as progesterone is also high in circulation. In terms of the cyclic nature of this, GnRH is going to stimulate FSH. FSH is going to stimulate the primary to secondary follicular development, which is going to stimulate estrogen to be released. Estrogen release is going to promote proliferation of the endometrium and promote the secondary phase of the cycle, which is going to allow for GnRH to stimulate both FSH and LH release. This is going to stimulate the secondary follicle development, leading to the ovulation, which is going to allow for increased levels of estrogen as well as progesterone to go into circulation. We will also see the initiation of inhibin coming into play in an attempt to ensure that only one ovulation takes place at a time. We're going to continue to have proliferation of the endometrium in preparation for implantation, as long as estrogen and progesterone both stay high. This will take place due to signals coming from the ovulate to the corpus luteum. If fertilization takes place, this continues, but not under the guise of the ovary, under the guise of the implanted fetus. However, if no fertilization takes place, the signal to maintain the corpus luteum stops and the corpus luteum begins to collapse. It begins to collapse and the level of estrogen and progesterone begin to plummet. This leads to the truncation of blood flow into the endometrium, leading to soughing, and the inhibition of the cycle is terminated due to the low levels of progesterone and estrogen, initiating the next sequence of events, meaning the next cycle will start. And so if we look at this cycle in terms of days of cycle within the circadian loop, because remember, this is a cyclic circadian loop, not just a normal high-low circadian loop that we'll see with the males. We have distinct areas where we're going to be noticing changes within estrogen and progesterone levels based off of changes of FSH and LH. Notice they're not huge spikes in FSH. There is the huge spike in LH that is associated with the change of menstrual phase. Notice the changes within the endometrium. Most of those changes within the endometrium are due to angiogenic signals stemming from epithelial growth within the glandular tissue. We're going to have growth in the glandular region in preparation for implantation to take place. So let's take a look at a cycle that's a lot simpler, and that's the male cycle. The male cycle is normal circadian, which means it's going to be high to low, high to low, high to low, high to low. The principal hormones that are going to come into play here are testosterone and the active form of testosterone known as 5-DHT. We'll still have activin and inhibin. We will have estradiol that's going to be functioning on the feedback loop in terms of its inhibitory effect on GnRH and LH. We will still have prolactin, we'll still have oxytocin as it relates to neuroanatomical changes, psychosexual arousal responses, and ejaculation. So we're going to start with normal signals coming into play. Now, unlike with the female, there is not as readily known evidence for kisspeptin activation within the male reproductive pathway. However, we still have to throw it in there. We have normal adipokine levels. We have normal age, normal nutrition, and environmental stimulus. This causes the pituitary to release both FSH and LH at the same time. FSH is going to head to the Satori cells. It's going to induce the production of inhibin. It's going to go to the spermatogenic cells and induce spermatogenesis. LH is going to head to the Leydig cells and induce the production and release of testosterone from the Leydig cells. Testosterone is going to head to the forming sperm during spermatogenesis and is going to assist FSH's function in producing functional sperm. Testosterone will be released into circulation. As it's released into circulation, it will inhibit Leydig cells. Coming from Sertoli cells will be the androgen binding protein, which will bind onto testosterone for its circulation. Free circulating testosterone will be converted into 5-DHT, which will induce gestational development for the male. It will also trigger secondary sexual characteristics during puberty, maintenance of those characteristics post-puberty, as well as anabolic and androgenic responses to stresses. Most of the testosterone that we see in adulthood for males is about maintaining fat-free mass, whereas the spikes of testosterone that we see during puberty are there to allow for the development of secondary sexual characteristics. Peripherally, an enzyme within the plasma known as aromatase will convert testosterone into estradiol. This will inhibit the amount of testosterone that's available, but it will also feed back onto the pituitary to inhibit the production of LH. Now, there's adipokines that are going to come into play here for both males and females. We see a little bit of the indication of adipokines on the pathway here, but we'll see a secondary adipokine signal in a second as we look at the effects of adiposity, that is body composition, on this regulation. So let's take a look at the male pathway. And so the male pathway we're looking at is a change of adipokines, in particular an elevation of leptin. Leptin is going to have a change on kisspeptin functionality, but what's also going to do is it's also going to inhibit Leydig cell production of testosterone, thereby reducing the amount of testosterone, and inhibit the spermatogenic cells, thereby inducing a reduction of spermatogenesis. At the same time, it's going to induce an increase of androgen binding proteins and an increase in the aromatase action within the plasma, thereby inducing even greater reduction of testosterone. Now, this is one way in which hyperadipostic men will have issues with their testosterone. The other way has to deal with what's going on within the gonads. And so as we start increasing adiposity, we start getting signals from leptin. What ends up happening is that leptin is going to induce, along with increased levels of non-esterified fatty acids, it's going to induce testicular macrophages to start to increase inflammatory signals, IL-6, IL-1, IL-2, and TNF-alpha, which is going to truncate the production of testosterone and start to increase the amount of pregnenolone and progesterone within the Leydig cells themselves. We will also start seeing a reduction in the hypophyseal signals for GnRH and LH, thereby reducing the amount of activation of cholesterol into pregnenolone, allowing for the development of testosterone. Additionally, we're going to see that increase of aromatase activity in the plasma, which means that any testosterone that is coming out of the testicle will get aromatase, thereby reducing even further the amount of testosterone available, thereby inducing even less androgenic responses for the male. This is where hyperadiposity is detrimental to the testosterone levels, and why for treating hyperadiposity, one of the things that we want to do is increase resistance exercise as opposed to endurance exercise, so as to offset the low levels of testosterone that we see from the hyperadipostic male. Now, for females, there's two issues that come into play. The first issue comes into play with hyperadiposity, that is too much fat, in which we change the levels of signals coming from kisspeptin. By changing the levels of signals coming from kisspeptin, we change LH responses, in which we usually don't see too much of a change of FSH, which means estrogen is normal in circulation. But what we do see is we do see an increase of sex hormone binding globulin, thereby decreasing the amount of estrogen at peripheral tissues. But what we do is we increase the amount of LH. And what this does is this extends the luteinizing phase within the ovulation cycle, increases progesterone and adrenal androgens going into circulation, thereby diminishing total ovarian output. This increases the relative risk for polycystic ovarian syndrome and can cause andrification of the tissues peripherally, where hyperadipostic females will start developing some secondary sexual characteristics that appear to be male. Now, if we happen to have hypoadiposity, that is where we have very low levels of fat. When it happens, we actually truncate kisspeptin signals. And by truncating kisspeptin signals, what we actually do is reduce both FSH and LH. we can actually reduce the amount of FSH in circulation to the point where we actually will cause a truncation of ovarian and follicular development and reduce ovulation. It can get to the point where we actually reduce menarche and reduce mammary gland hypertrophication. We lose any estradiol hooding. We increase andrification of body morphology, and we start having metabolic and cardiovascular issues due to low levels of estrogen.